So hi, everyone. This is Melissa Wilson again from AIM at Melanoma. Thanks again for joining us for Conversations with Melissa from Clinic to Living Room. Here we are. It's 7 o'clock on the East Coast, but I know it's really still early, 4 o'clock over there on the West Coast. Our special, wonderful guest tonight is Dr. Hamid, who is joining us from the Angeles Clinic and Research Institute. He's the chief of research out there, co-director of the cutaneous melanoma program at Cedars-Sinai Cancer Center. We're very happy that you joined us tonight. We're going to be talking about some updates from ASCO. For the viewers that maybe don't know what ASCO is, it's the American Society for Clinical Oncologists. They're responsible for a lot of the pioneering, for clinical research and advancing care of oncology patients. They have an annual meeting every year that actually just happened in the beginning of June, virtually, like everything else in our life these days. But there are all the cancer specialties are represented there, and melanoma especially is obviously important to our needs here. So we wanted to kind of give our patients and viewers a sort of update as to where things are going with ASCO. So thank you so much for joining us tonight.
Thank you so much for having.
Yeah, of course. We're really pleased. We've been having some really good conversations on here, so we're happy that we got you here. One of the things that is really great and that comes out of ASCO, at least in my opinion, is how sometimes the more difficult aspects of medicine seem to be teased out there. So there's always folks doing research in special, nooks and crannies of melanoma. And for me, one of the places that I find most interesting, not that it's all not interesting, but are, the folks that have CNS disease. For a really long time, they were excluded from a lot of the research. So it was pleasing to me that, some things had come out of ASCO this year, if you wanted to speak about that.
Yeah, well, I think, ASCO this year was virtual, obviously, which allowed a lot of people to get in there and spend time looking at the presentations. They did a great job of being rather fair, but also there were certain nuggets that came out as it relates to melanoma. You just had to sort of dig in to find them. And the first one, I think, was unbelievably amazing. It comes from an investigator that I know well, who's a huge contributor to the field in relation to what to do with leptomeningeal disease. And this is Bella Glitza, who's at MD Anderson. And she did a wonderful, as I try and bring up these slides to really do it justice, she did this study with intrathecal therapy, so intrathecal PD-1 therapy with Nivolumab. And what happened here is these are patients who could have failed anything, and even patients who failed systemic anti-CTLA-4 and systemic anti-PD-1 that came on looking for an option. They had leptomeningeal disease. This is therapy that has very, very poor prognosis, and it is a tough ask to treat a patient like this. So how did they get treated? These patients got treated with Nivolumab systemically, and then got intrathecal Nivolumab, small doses, increasing doses, and going forward. And basically, what she did here was look at how we could improve and what the responses were. And so, interestingly, they saw responses, not stability and neurological stability for extended periods of time, and ultimately, even better than that, were able to get a response seen in the leptomeningeal disease. Now, where does this trial go to next? This trial goes next to looking at higher doses of Nivolumab given intrathecally. And what does this trial really show? Well, for a long time, we felt that the brain metastases were very difficult to treat. We also felt that leptomeningeal disease was a poor prognosis, 4 to 6 weeks.
Right.
And we had made some huge inroads into treating brain metastases. As you'll remember, the Ipilimumab Nivolumab combination, Hussein Taubi published in the New England Journal, 55% response rates, long durations of response. And then our experience with BRAF and MEK targeting in the brain having similar response rates than systemic BRAF MEK, but very short disease control. What we've seen is both of those regimens could affect leptomeningeal disease, but the majority of patients that come to us have progressed off of those therapies. And this showed even patients who had had PD-1, CTLA-4, when they were put on this regimen, had disease control. So what's next? And what's next is our ability to look at higher doses and our ability to come back and combine this with others. So I'm just going to give a laundry list, and this is something that may come in the future. And of course, investigators like Dr. Klitzat, MD Anderson, Ryan Sullivan is looking at combinations for leptomeningeal disease. Priscilla Brasientos and the group at Mass General are looking at some of this stuff going forward. So next could be and will be and has been looking at cytokine therapy in the intrathecal space. We will talk about some of the newer drugs that are out there. What's been interesting is adoptive T-cell therapy and whether TIL can be introduced in there. And what's come is this idea that even though we felt that we could get high enough levels of therapies into the brain systemically, checkpoints, targeted agents, chemotherapy, we're now seeing that the next step is directly introducing them in. And the other thing is, this was a very well tolerated regimen.
That's what I was just going to ask, what the side effect profile looked like with that.
Very well tolerated, very well tolerated without significant issues. And so now, is that ready for prime time? Probably not. It's in a clinical trial right now. You can't just go down and ask for this from your physician. It really needs to be done on a clinical trial format. So.
Now, are they going to look at, and you may not know this, are they going to look at trying to incorporate multiple institutions in accruing patients to the trial? Or are they trying to keep it more local?
I'm sure that more institutions will come and do small. Yeah. And so that's an amazing, amazing breakthrough. And really, I started in melanoma and went on to immunotherapy, but the belief really is that what we do in melanoma really is not something that's siloed. It's not just for the melanoma patients.
Right.
Our experience with immunotherapy has brought forth a revolution for other solid tumors, combinational therapies, and the idea of dosing and predictive markers all come from the initial experience in melanoma. But guess what? As we do better with every other solid tumor, the incidence of brain metastases goes up. Now we're seeing patients with ovarian cancer, with triple-negative breast cancer, with genitourinary cancers, bladder cancers, showing up with brain mets, something we never saw before because their survivals were so low. And no doubt leptomeningeal disease will be the next thing to tackle. So it's very important abstract, one of, if not my favorite abstract at ASCO this year.
Yeah, I find all of the brain metastasis research really fascinating because you're right, people are living longer, and so these problems are becoming much more prevalent for sure. Along kind of the same lines of using, combinations, there's lots of talk, and I know our institution at the University of Pittsburgh has also done a lot of things with triplet therapy in melanoma, and it seems like it seems to be the way that a lot of the research seems to be going, is multiple combinations of medications together. So as far as updates from ASCO and triplet therapy, what is new there?
Right. So you can't begin the discussion about triplet therapy without just starting with the data that's come forth with BRAF/MEK and PD-1 versus BRAF/MEK alone. A couple of combinations being published, the first being Keynote 22, which is dabrafenib, trametinib, and Pembro, and then also the data that's come from Atezolizumab with Vemurafenib versus just Vemurafenib.
Right.
And have shown progression-free survival benefits and are going forth to FDA for review and possible approval. What we don't know, and what we're trying to figure out now, is what does that mean as far as being the first line therapy of choice?
Sure.
Obviously, we have other options, combination CTLA-4 PD-1, which we'll spend a lot of time talking about because there's a lot of data at ASCO. Single agent PD-1 inhibitors, that's a first line. And then the idea of what sequencing really means for us. And I think the best is yet to come for that. We have really got to understand the power of this triplet combination in the long term affecting survival. Now, we're now at a time where every tool in the toolbox that we want, CTLA-4, PD-1, BRAF/MEK, are available globally, and therefore we can sort of limit the biases in overall survival, right? So previous trials showed an overall survival benefit, and then you looked at it and you said, well, patients that progressed never went on to X, Y, and Z.
Right.
So that when you're looking at the ECOG trial of starting with BRAF/MEK or starting with CTLA-4 PD-1 and switching, which one first, that trial may read out, and we've already gone to another question of starting with triplet versus starting with combo immunotherapy. There's a lot to unpack there. Those answers did not come at ASCO, and we yet have to look at that triplet combination to evaluate which subsets benefit, because you really you see more toxicity, more grade 3 and 4 toxicity in the triplet combination. And concerns for physicians like mine that have practices like mine are that, look, the toxicity will be in so much that you'll have to stop and go with treatment, and the community will not be able to give the dose intensity that you need to see the benefit. What I'm clearly looking forward to is a breakdown of the subsets of patients that we're on. What do we know? Georgina Long and others published that patients that have more than 3 sites of disease, high LDH, those are the ones that have the poorer prognosis, right? That are treated with BRAF and MEK. So really, are we making a dent onto that subgroup by treating with triplet combination? One of the other things that did come from ASCO, again, I love it when great people present great data, and this is Paulo Acierto's poster on Vemurafenib, Atezo versus Vemurafenib, is that the incidence of brain mets, as a site of failure and relapse was less in those patients treated with triplet versus doublet. And so where do we go from there? We have to look at that data. We have to look at who those patients were. And really, that's an important combination that we'll somehow need to figure out as it relates to, combination checkpoint, what to choose first and where to go. And what's the benefit we get from checkpoint inhibition after using PD-1 alone in a triplet. But let's move off of that. There were other triplets that are upcoming. There's going to be checkpoint triplets. I say that on the heels of us opening cohorts on certain trials looking at PD-1 plus ICOS agonist plus TIM3 checkpoint inhibitor. So That's one that's going on. There will be more and more and more. There are CTLA-4 PD-1 LAG-3 combinations that are up and coming. And clearly we've known that looking to add another checkpoint on at progression can restore response. What we're going to be seeing is if you start with a triplet initially, can you benefit the patient more than just lining them up one after the other? A lot to go into there, and a lot coming forward. We know also that there are other tools. VEGF targeting has been discussed, and there was a lot of that at ASCO.
VEGF with other agents or VEGF as single?
VEGF with like lenvatinib. So let me give you an example because that's the best way to do it. And I gotta remember the it's in mucosal melanomas. It was data presented by the group in Beijing of using a targeted VEGF agent and a PD-1 agent in patients with mucosal melanoma.
Mm-hmm. Which is another group of patients that, you know, don't have a lot of love in terms of treatment options.
Absolutely. They don't get a lot of love. Some trials exclude them directly, partly because they have a much lower response rate to a single agent PD-1. Instead of having a 40% response rate, they have something in the teens. And then when you go into combination, the response rates increase. They get up to like 30% or more. And when you look at that, and you say to yourself, well, what do we do here? VEGF therapy has been an interesting combination. And I was really trying to find this, but it was a VEGF targeted treatment in addition to a PD-1. And these were given together in mucosal melanoma patients who'd had chemotherapy before or were immune naive. And what we saw here is that the response rates increased about 48% response rates in mucosal melanoma.
Wow.
And that's something that really has not been seen before, you know? And
that's
so this
quite impressive, actually. That's better than any data I've seen for any other thing. So that's great.
That's right. So this is vorolanib in combination with toripalimab. Then that's a Chinese PD-1 and VEGF agent. So 40 patients were enrolled, 38 evaluable. And so what you're seeing is that people had really good responses going forward. So very lovely there. Okay?
Yeah, that's great data.
So what else can we say here?
Yeah, I don't want to jump topics before you're done talking about the, you know, further triplet therapies. But I also wanted to ask, and there was a question that kind of came across earlier this week in email. That
Wait, let me go back and tell you.
Sorry.
That the drugs that were in that combination that had an overall response rate of 48% were axitinib and then another PD-1. But then the other combination was also presented with high response rates.
Okay. So that's something for mucosal melanoma patients to really look forward to, potentially as a US trial availability as well.
Absolutely, and it's coming. It's really coming. There are drugs that target VEGF that have been available, and so some doctors are using it off-label, but combinations with lenvatinib, which is a VEGF-targeted agent that is an E-side drug, along with Pembrolizumab, looking at it in second-line and PD-1 failures, they've seen responses. There's a randomized phase 3 trial looking at single-agent PD-1 versus that combination. That's all going to read out shortly. We know that tumors that are less responsive to PD-1 therapy have higher levels of VEGF.
Mm-hmm.
And so blocking VEGF can be a way to reignite the immune system. We know that high levels of VEGF inhibit dendritic cell function, and they inhibit the immune system. So very straightforward ideas. Steve Hody from the Farber has done trials of Avastin and anti-CTLA-4, Avastin and anti-PD-1, Avastin and Ipi-Nivo. Those are straightforward trials that are very promising.
Right, which those are from I remember participating in some of those trials that he did, and we didn't really see a lot of significant toxicities as well. So with, CTLA-4, when you're looking at something, like PD-1 that has a, potentially less severe toxicity profile, that's a really exciting combination.
True. Very true.
So, did you happen to, because I wasn't unfortunately able to attend ASCO this year, so I'm waiting for the educational materials to get released. Were there anything that was interesting for like ocular melanoma? Because, we spoke about mucosal, the other group that kind of feels, very neglected in terms of clinical trial research are the ocular group. And I wasn't sure if there was anything that came across from them as well.
Right. So what I would say as it relates to the ocular melanoma is that we're all still waiting to see the data from tebentafusp, which is the bispecific that targets CD3 and GP100.
Yeah.
And this is a bispecific antibody from Immunocore that got orphan designation by the FDA, and the data is coming forth. Initial data presented by Rich Carvajal, Mark Middleton, and others showed a 70% 1-year survival, very important, and therefore it's led to a second-line study, which is fully accrued, and then a randomized untreated study, first line, between that drug, IMC GP100, versus investigators' choice of PD-1, CTLA-4, or other therapies. And that's fully accrued. We're waiting for that information. I do think that we'll transition to talk about other therapies, and adoptive therapy is an important treatment for cutaneous melanoma.
Yeah.
And there's a great data that was presented at ASCO, but also there was an unbelievably good data presented previously about that type of therapy for ocular melanoma. What is going to happen is, as investigators, we're pushing to be able to find a drug and then show that it has benefit, and probably look into some adjuvant trials for patients that are high risk, and hope to change the paradigm for ocular melanoma. Ocular melanoma, very hard to find treatments for, but I would also say that this is the reason why AMET melanoma exists, is to send the patients to the right places for those. So let me do a little plug for my place. So at the Angeles Clinic, we see a lot of melanoma, and a majority of our trials, just like at your place with Jason Luke, no longer do we look for like a trial of X in mucosal melanoma, a trial of Y in ocular melanoma. What Jason and I have done mimics each other, in that we've looked to become places that we have novel agents in the phase 1, first in human, and then in combinations, in order to allow those ocular melanoma patients in. And so I would stress that patients with ocular melanoma should do a couple of things. Always seek a second opinion at a center of excellence. That doesn't mean that you're going to have treatment there, or that there will always be treatment there for you, but you will have the experience of someone to guide your path.
Right.
And you will always have the ability that when you hit a fork in the road, to be able to be considered for novel therapies, just like every other solid tumor. So I'd give you the example of this bispecific, but there are other bispecifics targeting proteins that are expressed in ocular melanoma, like PRAME. And so that's one that we screen our patients for. There are also, I think what we've learned is that, yes, it's harder to get an immune response in ocular melanoma. We know that the tumor mutational burdens are low, T-cell infiltration is low, but maybe that requires one of these triplet trials that we talked about. And those are, those exist at centers like ours.
Mm-hmm.
So we're currently accruing our ocular melanoma patients to trials that that have bispecifics plus PD-1, combination checkpoints, local therapies. So we've had the ability for the whole field of oncolytics to move from just local therapy, okay? Let's find a node, let's find a dermal lesion, into moving into intrahepatic injections has been an important one. And at ASCO, there was data with Leptomeningeal
Mm-hmm.
that herpetic virus that codes for GM-CSF. We're looking at it in multiple solid tumors, but also it's in a randomized trial in melanoma. There was a trial that was presented by Randy Hecht from UCLA of giving that directly into hepatic tumors to get an immune response.
Oh,
So
neat.
that's what I would say, that we steer our patients towards these newer agents, because clearly local infusions of chemotherapy are important in disease control there, but for a systemic response, you need to find something better.
Right. And sure. And one of the things that I think patients sometimes forget, and we see a lot, is that, it's okay to get a second opinion. It's okay that you travel maybe, once, or send your records to a center like yours, and like what we see with Dr. Luke at our institution, to see what's out there. Because a lot of we've run across patients that, had they come initially and been able to be accrued into some of these earlier phase trials, they would have had multiple options, as opposed to just the standard of care single agent PD-1, especially in ocular. Like, patients are just afraid, I think, sometimes to reach out to institutions like ours, even if they can't physically travel there, to see what the options are. And I know, I'm sure that your center does that quite a bit.
Now, I would agree with what you're saying there. Yes, it's hard. It's hard to get people, and it's very difficult, really, given what's happening in the world today, to also travel. But guess what? There's also another benefit. The ability to do virtual visits now
Mm-hmm.
has become, it's exploded. It's a huge benefit. You can't travel to go to see, let's not pick on Dr. Luke, or you can't travel to see Dr. Carvajal at Columbia. Well, get a virtual visit with Dr. Carvajal.
Sure.
Dr. Carvajal can introduce you to the person who he can collaborate with in your local institution. You've gotten an opinion, you want another opinion, easily you can do that. So we're open at Angela's clinic for virtual visits all the time. It's become one of the greatest benefits of the inability to travel to visits, is that our healthcare system has now allowed these types of visits. Just like I'm talking to you.
Right.
I get on the FaceTime, or this. Let me sound like a tech novice. I get on the FaceTime. I get on the FaceTime. I log into the Zoom, and we have one of these meetings, and we discuss what's available. And clearly, it's not you don't make that connection initially, you're on the radar for that physician. And most clinics like ours have a running list, and if something comes up, and we will reach out to you.
Sure. So as far as, adoptive therapy and TILs, I know that in the past there were only a few centers that were able to actually do this due to part acquisition of tissue and everything like that. So, is this going to become a little bit more prevalent in other areas? Because there's a lot of folks, especially a lot of the folks that reach out to AIM, they're in community centers. They don't have oncologists with large research centers accessible to them. We get a lot of, as you know, the ask an expert line for them, and I get a lot of questions about, like, where can I get TIL therapy? Where can I get adoptive T therapy? What is the closest institution to mine? And a lot of these folks are, states and states away from someone that has the capability of performing these types of things. Is this going to be a little easier in the future moving forward?
Well, I think what we're really going to find is that the ability to offer adoptive T therapy is going to be greater and greater and greater. So I've been introduced to this whole experience through our collaboration with Iovance on their trials. So Iovance, again, presented data from their adoptive T platform at ASCO, an update in what they did and what they saw. Remember, in order to do this, you take a piece of tumor out of the patient, wherever it is, and then you send that tumor. In the past, it was at your center.
Right.
So whether you were at NIH or at Moffitt or at MD Anderson, et cetera, et cetera. Only a handful of places did this. They had huge lines to get in because of the surgical portion of it and the fact that you needed a GCP facility to, take that tumor, identify the T cells, grow the T cells to billions and billions. And then what happened was patient came in, received non-myeloablative chemotherapy, just enough chemotherapy to get rid of the T cells that are there. And then they were hooked up, and their own T cells, which had been grown up, were infused, and they received IL-2. So most centers can do the surgery. Most centers can put a patient in the ICU, give chemo, and then, infuse cells. We do it with Provenge, and then give high-dose IL-2. What most centers don't have is the ability to grow the T cells.
Right.
This Iovance protocol looked into doing that and has been very successful in over 100 patients in doing that. Cohort 2 patients were presented. These are patients who had failed PD-1, and if they had a BRAF mutation, would have had to have had a BRAF targeted agent. 100% of the patients had progressed on a PD-1. About 80+% had seen the CTLA-4. A quarter of the patients were BRAF mutated and had seen BRAF mutant. And what they saw here was a near 40% response rate. Durable responses, where the median duration of response has not been seen, patients out 2 years or more. The median average follow-up is 18 months, which is good. And then from there, the breakdown of those patients who've had response, you look at it, and about 80% of those patients are patients whose best response to PD-1 was progressive disease. So these are the primary refractory patients. These are patients that we spent an extended amount of time trying to figure out what to do with them. Here comes something. And clearly, again, this is a paradigm that's not just a melanoma paradigm. There are clinical trials ongoing. Iovance has done data and trials and presented data on cervical cancer. That's their second tumor of record. They're looking at it in lung cancer and other cancers going forward. They currently have a clinical protocol looking at untreated patients being treated with combination of PD-1 plus TIL. So that's ongoing still. And hopefully the data in the most recent cohort 4, like 60 patients, is going to the FDA for evaluation.
So if it were to be approved by the FDA, so this would be for specifically refractory patients. It wouldn't be necessarily for first line therapy, correct?
It would be, the label would be for refractory.
Yeah,
I wouldn't know I couldn't think of anyone who would go to this therapy before, given the successes we've seen with immunotherapy or combination checkpoint.
Yeah. What so tissue acquisition for the iAdvance trial, just so that our viewers are aware, that's something that, like, when they either becomes FDA approved or whatever, it's going to be a process that they can do at their own institution and send away to get the
That's right.
Like, that'll be something that they are able to do. I get that question all the time. That's why I just want to make sure that people will understand that that is possible somewhere else.
That is possible. It is something that they would do, and it is possible.
Good. So as AIM opened up some U.S. locations for the International Tissue Bank Consortium, and it's primarily fresh frozen primary tumor, as opposed to folks that on clinical trials everywhere, they're taking tissue from folks that are on metastatic trials and using that as part of research. But this tissue bank is really for fresh frozen primary tissue. Can you help everyone understand kind of why primary melanoma tissue would be really important for research, versus metastatic tumor? Like, why is, I want our folks to understand why this is such an important development for research.
Right. So I would say it's not just initial fresh tissue, but clearly we need to start there.
Yeah.
The whole idea of a biobank is something that can unlock a lot of answers for us.
Yep.
Okay. And we're trying to do that here. I want to commend AIM for putting together working with Skin of Steel and collaborating in order to put together a brain mets tissue bank and an initial biobank, and working throughout. And I think UPMC has been the strongest partner taking that forward. So why is that important? Well, we really don't have the predictive markers to tell you if you're going to respond to a single agent checkpoint, combination checkpoint. We're really doing this without a lot of light on the path ahead. So someone gets in and gets into the car to go on their path for therapy. It's not as well lit the road for us to take.
Sure.
Where we could figure this out and better is understanding what is in the tissue to begin with, predictive markers, whether it's circulating DNA, tissue markers, whether it's the microbiome of the patient, and understanding how that changes through therapy, whether we can have early indicators of resistance, and what the tissue and the microenvironment of a patient who is going to be primary refractory looks like compared with someone who's going to have an amazing response.
Sure.
Because you brought up the right question. Who would want to have an adoptive T-cell therapy as their first-line therapy? Right. I know who would. The person that we identify through our biobank of not having a chance of ever responding to checkpoint, right? Or the patient that we identify who would respond only for a short amount of time. Or the patient that we identify that would have significant toxicities from that therapy.
Sure, and if we could tell all that from a primary tumor and sort of predict the course of their treatment, that would be life-changing.
Well, I think this is not a novel idea. This is a very, very, I mean, if you say it to anyone, there's a huge buy-in. And the
Mhm.
whole idea behind how people, the whole idea of like a company like Theranos, you know, where they sell the fact that they could tell you about your illnesses and your future from
Mhm.
one drop of blood, it doesn't come from sci-fi, it comes from science.
Right.
But unfortunately, what happened is someone came up with this brilliant idea, and then we said, "Oh, the idea starts here," and everyone wanted it to be already done and
Sure.
in one. And the only way to do it is to have a biobank, to look at fresh tissue, to follow tissue, to biopsy areas of recurrence, to biopsy areas of response versus non-response, and those exist on the same patient.
Sure. And this
Um,
is, I mean, one of the things to keep in mind too with AIM is that this tissue bank is also, it's going to have patient information, like depersonalized patient information. So you're going to, like, as a researcher, you're going to be able to know like what their skin type was, their sunburn history, their history of family, malignancy, especially skin cancers. They're also trying to collect blood and urine samples that they're going to have here. So there's going to be all of this data that's going to be able to be accessed from fresh tumor. And that is really, I think, helpful in terms of, harboring future research to try to, identify like multiple biomarkers.
One of my greatest regrets as an investigator on multiple clinical trials was that at the time we were doing that work here at Angeles, we were not scaled enough
Okay.
to do that. And it's taken our collaboration now at the Angeles Clinic with Cedars-Sinai Medical Center and our ability to recruit someone like Mark Ferries, who's the head of surgical oncology here, to get the idea of tissue banking and having a biobank. Now, how does that differ from what AIM is doing? It doesn't differ at all. The idea is to be able to offer this to everyone, every place, so that we can even share tissue, that we can ensure buy-in from all of our patients. That's the next step in advocacy,
Sure.
is getting this information to the right scientists, to the right investigators, to the right centers.
Because right now I think there's 4 different locations in the United States, and I think there's 2 international locations that are going to be added. So I think it's also helpful because, if we're able to capture all of this tissue and data from not only the places that have these banks, but also other states that can send their tissue there, it'll give us a broader scope of not only the places that are centers like your center and us in cloudy Pittsburgh, but also sort of a broader sense of what this looks like across the United States, which I think is a really helpful thing as well. So
Agreed.
lots of things to look forward to. We're getting late in our discussion. I feel like we literally could spend maybe 3 or 4 days talking about all of research for melanoma, but I wanted to just kind of talk about what are the newer, like what are some new targeted things that we can look forward to in terms of for future research? Because there's a couple of questions that folks have kind of chimed in on as we've been going along, but I want to kind of talk of what does the future look like for targeted therapy for us visitors.
So I would say what does the future hold for us is number one, combinations, figuring out resistance, but also newer agents. And you go to ASCO, you look for something that gives you an idea of what's next and how can we improve. And one of the things that I'm a big CTLA-4 believer.
Okay.
The toxicities have been difficult. And as we're looking forward to understanding those toxicities, there are newer agents that hopefully will have better on-target immune activity and less off-target toxicity. So as far as at ASCO, there's a trial of ONC392. It's a CTLA-4 type drug that supposedly has less toxicity, but there are other drugs similar, like Probody CTLA-4, so newer agent, next generation CTLA-4. There are other drugs, and this is one that came to my attention. Because Jason Luke presented it. Hey, it's a bispecific, the molecule that binds PD-1 and LAG-3.
Yeah.
And the dual targeting was well tolerated, had good response, and may have less toxicity going forward. And so that's a great one that I saw at ASCO. The whole bispecific field in melanoma is interesting because it can really cause T-cell trafficking, can bring T-cells in without needing to do something as radical as like a CAR T or
right.
a TIL type of therapy. Let's see, what else was there? There was a great something that was sitting in a small molecule, which is a glycogen synthase kinase inhibitor. And this was the slides are available. It's a drug that helps to inhibit GSK3 beta, and it leads to degradation of anti-apoptotic products in the cell. Okay, why is that important? Well, it's got activity in multiple solid tumors. It's been combined with chemo and targeted. But if you look at the presentation, there was a patient who failed, who was refractory to immune checkpoint and also BRAF MEK inhibitors, and got onto this therapy, and they presented it with all the PET images, and it got a complete response.
Wow.
This patient had a complete response. Not only was not only was it like that, but there was response in brain lesions. So
that's impressive.
Very impressive as you're going forward. And what do you say about that? Well, you say, interesting. I'm interested in seeing where they go next with this drug. Mm-hmm. Obviously, it's a one-off, but they saw good responses in pancreatic cancer patients ongoing for weeks. And always pancreas is a place where they say, therapies fail. They ultimately go to pancreas and they fail, but this is not true. Their development, the drug is being developed and is moving forward.
Cool. So one of the questions that kind of came across, and it's one that we get all the time from folks, is, were there differences in patient outcomes, or was there any information presented at ASCO about like duration of PD-1 therapy and folks that had, 2 years of maintenance versus, post CR versus 1 year versus 6 months? Was there any kind of data presented about duration of PD-1 therapy? That's a hot topic that happens to be asked quite a bit. I know that there are some clinical trials that are about to start or are already started at institutions regarding, various stop points. But I was just curious for our viewers if there were any further data presented.
Well, Mike Postow presented some good data of giving 2 doses and then, stopping if you had a good response after 2 doses and just going 2 doses of Ipi-Nivo and then just going on to Nivo and hoping to get best response but not see the toxicity. Well, guess what? Majority of the toxicity was seen post 2 doses.
Yeah.
So that's an interesting point there. So that's going into a bigger trial. The data from Keynote 6, looking at the first line PD-1 for 2 years, how people did once they stopped. And it did show that, again, what we've seen before, if you were in a complete response, really, you really did well. But if you were in a partial response, you had a risk of progressing, and then you were re-induced and had a response. So how do I work it? I think in melanoma standard has been, if you're getting a complete response, you can go a couple doses after the complete response, ensure that that complete response is solid, and then stop. And if for everyone else, I go on to 2 years and then consider stopping and re-induce if they progress. Clearly, there is no guidance in any other solid tumor, although most trials now are looking at 2 years period.
Right. One of the other questions that came across in our Q&A are any update on TVEC and the CRISPR treatment/trials?
The update on TVEC is we're still waiting for the randomized trial of TVEC Pembro versus Pembro in the first line. The update on TVEC also comes in the fact that there was the data that I spoke to about Randy Heck and others looking at intrahepatic injection of therapy.
Mm-hmm.
So there is a lot there. There's still a lot there to unpack. But there are a lot of oncolytics that are going forward. The majority are going to look at injection into viscera. There are first-line randomized trials. I think, and of course, not to mention that there's a SWOG trial looking at TVEC plus PD-1 after PD-1 failure. Ari Vandewey is doing that, and through SWOG. I do think that, clearly oncolytics or injectables and TVEC itself has a role in low volume, in transit,
Localized disease.
unresectable localized disease, yeah. And its benefit in the metastatic setting has yet to be clarified for us.
Sure.
But I think it's, the entry into understanding local therapies and where to go. Look, in melanoma, we know if you have hepatic metastases, if you have liver metastases, doesn't matter how much disease you have and how many other places, you will do worse than someone who is exactly like you but doesn't have liver metastases. Mm-hmm. So clearly there's something immunosuppressive there. Clearly, if we can prime the tumor microenvironment with those types of therapies, we can benefit. That's what I would say.
So one of the other questions that came across is, what is the biggest reason a patient does not respond to immunotherapy? I feel like there's so many possibilities that we still don't know.
Well, we don't know. We have an indication, right? Those who are not already inflamed. We know the interferon gamma signature. That's an inflamed environment. Those patients do better. Those patients who have less T-cell infiltration, those do worse, Right. We know those things. But whoever asked that question, the answer to your question lies in the biobank.
Yeah.
And so that's where we should be looking to, push and get data and take a look and go from there.
Right. One of the other questions that came across is do we have any information or data that came about melanoma-associated retinopathy? This is actually a question. I've had more questions in the last month about melanoma-associated retinopathy.
Oh, yeah, Mars. We've seen it.
I was like, honestly, I have not had anybody that I've seen with this. So I've been just background with me. I've been practicing at University of Pittsburgh for about 15 years now, and I have only seen one person with melanoma-associated retinopathy. So I was like, I'm not really totally sure that I'm the most qualified person to answer these questions.
Yeah, it's basically you're getting an immune response, and that immune response, just like, I have some vitiligo and others have vitiligo, sure. Just like vitiligo, it's an immune response to your pigmented cells in your retina. And so
You treat it just like you would any other immune response.
that's right. You give immune suppressants. I wouldn't know, but if I had someone who's refractory, there have been episodes of injecting and local injections into the eye. I would not do that. I would refer them to someone who has the expertise. But look, at days like this, we inject multiple different things into the eye. We inject the Avastin into the eye. We totally take out the vitreous in certain people and just give them gel in the eye. So I think in a place like that, then you refer them to a ocular center of excellence.
Yeah. We're going to take this one last question, and then I think we're going to call it a night. Keith asks, was there any annual update from anyone related to patient status from patients who had Ipi-Nivo like many years, 5 years ago? So I guess what he's asking is like, from folks that had immunotherapy with say Ipi-Nivo many years ago, how many of those people, like long-term data, had progressed versus had a CR versus, was there any longer-term data available?
So I think that the answer to that is a general answer. James Larkin from England had published in the New England Journal the 5-year follow-up of that trial. But as we go further and further, what we've realized is, as you treat patients more, you can get deeper responses and more durable benefit. That toxicity and coming off for toxicity does not obviate your response. So patients who've come off for toxicity have durable responses. It is still and remains a great standard for patients. There was updated data looking at the BRAF mutant patients, and clearly, the trial was not powered to look at Ipi-Nivo versus Nivo, but there's some data to show that those patients have higher response rates. The BRAF mutant patients have higher response rates and more durable with the combination. Mm-hmm. I think that combo is coming to the fore in BRAF mutant patients.
Sure. I just wanted to, again, take the opportunity to thank you for spending so much time with us tonight. I feel like you're such a wealth of information, and we could probably do 2 more of these webinars just talking about research. So, so much.
Well, I think I'm going to just end by saying that, one of the greatest losses has been the loss of Valerie Guild. Mm-hmm. Around this time. I met Val 11 years ago, and we talked and drew out an idea for these AMET melanoma symposia on the back of a napkin at some meeting, whether it was MRA or ASCO or ESMO. And clearly, this woman was a phoenix. Mm-hmm. And what she's done. If you took everything that AMET melanoma has been able to do through Valerie's guidance and now through Samantha Gill's guidance, start the IMWG, start the biobank initiative, start a site for cutaneous non-melanomatous cutaneous malignancies, the nursing stuff, the advocacy, the legislative work. And if you took that resume and put it down, I think every academic would take that resume over what they have achieved in their lifetime. So I think that's an amazing, amazing goal. And it's always been my honor and pleasure to be part of AIM and what it stands for. And I think what Val has done is given people like myself, I reference Jason a lot, because Jason Lukes has been part of that, and yourself and others, the momentum to just pull this thing and go forward.
Yeah, and I mean, not only that, but just has given patients such a great resource for educating themselves and having, resources to look for how they can help themselves, and making patients their own advocates has been such a great thing. So I think, gosh, all of us Val has left such a great legacy for everyone to continue for sure.
Absolutely. Absolutely.
Well, I hope you have a wonderful night. Thank you again for joining us.
Thanks everyone for joining. I look forward to another update down the line.
Sounds like a plan. Have a good night.
Bye-bye.
Bye.